Welcome back. Today our guest is from Saddleback Medical Center, Dr. Samer Kanan, who is a thoracic surgeon. He is going to talk to us about robotic-assisted thoracic surgery that treats lung cancer. Dr. Kanan, welcome.
Oh, thank you.
So before we get into the actual surgery, why don't you tell me a little bit about the areas that you specialize in?
Oh, great. Yeah, I'm a thoracic surgeon, which thoracic is a fancy term for the chest, so anything in the chest. I focus on non-cardiac, meaning I don't do bypass surgery, but I'll do everything else. Lung cancer is the predominant condition I treat, but it could be the thymus, diaphragm, esophagus, lymph nodes, anything in the chest, pleura or the lining of the chest. But lung cancer and particularly surgery on patients' lungs for lung cancer is my most common condition or procedures I do, and my passion, so to speak, of what I like to do.
Right. Now, before we started the show, we were talking about, how long does it take to actually become the type of surgeon that, I know you've been through a lot of training,
Yes.
a lot of schooling, but sometimes people have a particular passion, like you said, for lung cancer. So how did you get involved with that?
Well, during my training, you find what you spend a lot of time doing and enjoying, and I was fortunate to go to some really great institutions like USC and the Brigham Harvard's hospital, and during that time I learned that spending my time as a thoracic surgeon, where I could spend time as a thoracic kind of a surgical oncologist. There are medical and radiation, but I see myself as a surgical oncologist, and so having that relationship with my patients is really important, and being able to take care of them for years, hopefully, is what I enjoy, and being able to cure them from cancer is my goal. So I really found that very rewarding, and that's kind of where I gravitated, and I'm so happy I did.
That's excellent. Now, okay, so we've got robotic-assisted thoracic surgery now. So how has that changed the way that you do surgery now?
Absolutely. Well, we used to do an open surgery. It was called thoracotomy, and explain to patients, we'd make a large incision and sometimes cut out a rib or break a rib.
Oh gosh.
They'd be in the hospital 10, 14 days. It might take them months, 3-6 months to recover. And we switched over to video assisted. We call that VATS, and did that for a few years. And it was an advantage, smaller incisions, but it had limitations. It was two-dimensional, and the instruments were kind of fixed. And so robotic surgery developed, and then became applicable to the thoracic field. And what was nice about that is it was now three-dimensional.
Right. And
you could zoom in. Instead of the robot arms, now your hands could move. So the precision, we use the term articulation, the ability to rotate and move your wrists and hands. It's incredible. I can now do operations that I think are better cancer operations, because I can see the lymph nodes, I can take them all out, I can take the tumor. It's a safer operation. I can see blood vessels. I dissect everything nice and precisely. And, and so instead of a week in the hospital, most of my patients are 2 or 3 nights in the hospital.
Oh, wow.
1 or 2 weeks, and they're back in my office, and they're almost back to full recovery.
Okay.
What I've noticed is able to offer operations to patients who historically we couldn't offer an operation. They were too high risk, or they. So I've operated on people in their 80s and 90s. They've done fantastic. Pain is a huge improvement. Many of my patients have no pain.
Wow.
So I send them home on prescriptions. Half of them tell me they don't even fill their prescriptions.
Right.
So it's really, I think, revolutionized the idea that it's the same cancer operation. It's just 8 millimeter.
Well, I was going to say, so now you don't have the real large one now, right?
3 or 4 8 millimeter incisions.
Okay.
And that just reduces the pain. It allows a faster return to work or family or the regular activities.
Right.
And it's really, I think, allowed surgeons to, again, do a better, safer operation, which is really the goal. Right?
Exactly.
You want to cure patients, and so I'm excited, and I think that the technology has developed, and it's exciting.
So you don't have to break a rib doing this either,
No.
right? You just sort of bypass it.
Correct.
That's great.
Yeah,
And you
no
said you
break.
could zoom in.
Right. What's nice is the video assisted camera, and historically was just a simple camera. The robot actually, when the way the operation works is the patient's asleep.
Yes.
I'll make multiple small incisions and I'll put my instruments, and then there's a console, so I bring the robotic machine and connect it to these ports.
Okay.
Put my instruments in, and then I will go to the console and I'll take over. So I'm doing the operation, the robot's allowing me to zoom in and do these fine maneuvers.
Okay.
The camera is wonderful because it's two eyes. So the camera itself has two channels, one for the left eye, one for the right eye.
Wow.
So the precision to be able to zoom in and see, in 3D is a huge advantage.
Okay.
And then of course, when I'm done with the operation and the tumor's been removed, I come back in, remove the instruments, close everything up, and it can take an hour to 2.5 hours, depending on how complex the operation.
Right.
But, and again, the robot will mimic your hand movements. So when you sit at the console and you move this, then the actual instrument is doing the exact same thing that your hands are doing. Right. And some of the fine things we like to. When you zoom into the robot, we will do some demos for patients or community events, and you'll have, like, for example, a $5 bill, and you can zoom in and you can actually see on the Lincoln Memorial all the names of the states on the $5 bill by zooming in with the robot.
Wow.
So I challenge people to take your $5 bill out and be able to see all those states, because you won't be able to.
No. Well, maybe next time you come on, we'll have some video that would actually show the robotic operation or something similar.
Great.
That would be awesome. So lung cancer, how do people prevent lung cancer?
Well, lung cancer is unfortunately the #1 killer of all cancers, and that's not just for men but also for women. Smoking is the #1. 90% of people who get lung cancer were former smokers.
Right.
Pollution does play a role. So if people are exposed to pollution or environmental, meaning if you work in a certain job that you're on fumes or a lot of inhalants, so obviously protecting yourself with a mask, but making sure that people quit smoking or don't start smoking.
Right.
Secondhand smoke is a small risk. It's not as bad if you're, but it'd be nice if you don't get exposed to secondhand smoke. And California is very progressive in terms of our restaurants and all the places to make sure we don't have smoking in public places. But the #1 is quitting smoking.
Right. Well, it's surprising to me, with all of the reports that you have out there, why are people still smoking?
It's a great question. When the Surgeon General came out and said that smoking had caused cancer, we had about 50 million Americans who were smokers or former smokers. That number did drop down to about 22 million, but that hasn't changed. So we got the number down, but we haven't been able to. So I think some of it's education, and I wish I had that magic answer, but I don't know. It seems to be that there's certain people who want, and that's a hard habit to break. Right, exactly.
And then at what point do you think you need to have screening done to make sure that you don't have any lung cancer? What are some of the...
Oh, that's a great question. Lung cancer screening has kind of been a topic that we've debated in the medical circle for a long time. And we didn't have a good answer. We tried chest x-ray, that didn't work very well. And very recently, there was a New England Journal of Medicine article that showed that screening with CAT scans for lung cancer saved lives. And it took time, and eventually it got approved. And so there's a group of patients that the study showed. So if you're over the age of 55 to about the age of 75, and you were a former smoker, and you didn't have any symptoms, meaning chest pain or coughing and things like that, that you would get a yearly lung cancer screening could save lives. It would detect cancers. And the CAT scan, too, for patients who are worried, it's a low-dose screening, so it's just a little bit more radiation than an x-ray.
Okay.
But the detail of a CAT scan is so much better.
Right.
I tell patients the difference between an x-ray and a CAT scan is like maybe a 2-dimensional picture versus a 3-dimensional movie.
Oh, wow.
Right, so the ability to see and find things. And if your lung cancer screening is abnormal, then they'll have you see a specialist and deal. And if it's clear, then you keep getting it every year.
Okay.
You know, for me, I think the passion when it comes to lung cancer is get people to not smoke or quit. And if you were a former smoker, I encourage everyone to ask your doctor about getting a lung cancer screening.
Okay.
And if you happen to have something and you need to have surgery on your lung, I encourage patients to find a robotic surgeon who can do your lung surgery, because it's just a better, safer, you know, better outcome surgery. Hopefully they won't need the surgery. Hopefully they quit or they don't smoke in the first place. But if they do, we can catch it with a lung cancer screening, and if so, then we can do kind of state-of-the-art surgery if they need it.
So when someone is smoking, is it like, what if somebody only smoked for a year and then you have somebody who smoked for 30 years? Is there still the risk of the year?
Yes, but it's a lot smaller.
Okay.
It is definitely related to not only how long you smoke, but how much you smoke.
Okay.
So we use the term pack year. So if you smoke 3 packs a day for a year, that you would have 3-pack year. Versus if you smoked half a pack for 5 years, you'd only have 2.5-pack year.
I see.
So it's not just the amount of the cigarettes, but also how long we kind of multiply them, and that's how you find out.
I see. All right, well, that's good to know, because I would imagine that people would be like, well, you know, I only smoked so much, but actually it could be just as bad.
Yes,
So,
no, it could be. So, and you know, unfortunately, some people, genetics plays a role. We're trying to find all those things out, but even a small exposure, if you have the certain genes, could put you at higher risk than somebody who might have had more exposure, but they don't have those genes. And
so there is no gene, is there a gene test for that at all? Because I know they're starting to do that with breast cancer.
Correct. For lung cancer, they are, in the tumor, we're finding mutations, and if you have those, then we're finding that there are medications and things that can help you. So,
good, great. Well, gosh, great information.
Well, thank you.
Thank you so much for being on. I really appreciate it.
My pleasure, and this has been great. Thank you.
All right, thank you. And if you have any questions or need more information, you can always go to memorialcare.org/SB cancer. We'll be right back after this.